I will have a pleasure to be here. Sorry for my delay, because sometimes it's impossible to do two things at the same time in the same place. And I have a huge pleasure to share this session with Armand. First of all, I'd like to introduce Professor Rinaldo Bellomo. You see, that now I'm completely focused on. And he will talk about the physiology of prone position.
Thank you very much.
Bellomo, it's my pleasure that you are here.
Not a problem. That's fine. So it's a treatment that's emerged for the management of ARDS, and it's well known to lead to significant gas exchange improvements and appears quite safe if executed by a trained, coordinated team. The physiological effects on prone positioning have been studied in ARDS and also in COVID ARDS, but other aspects of the physiological effect have been less well studied, in particular the cardiovascular events. Let me just remind you what we know in terms of lung recruitment and changes in oxygenation. This is work by Luciano Gattinoni's group, looking at potential mechanisms of improvement in gas exchange with prone positioning. They looked at the population of 25 patients with COVID ARDS, and they compared the supine position of 5 centimeters of PEEP to the prone position with 5 centimeters of PEEP to a recruitment maneuver in the supine position with 35 centimeters of PEEP. And they were able to demonstrate that there was more gas volume and less atelectatic tissue, but also that a higher peak inspiratory pressure was applied during the prone position. And you can see in the top panel that there is an improvement in aerated tissue with prone positioning, which is very similar to that achieved in the bottom panel with the application of recruitment at 35 centimeters of positive pressure. You can also see that with the passage of time in these patients, there are different levels of consolidation versus atelectasis, with atelectasis being dominant at the beginning and consolidation being dominant later on, with different implications in terms of what you can achieve with prone positioning. Another investigation has tried to address in a group of 20 patients how prone positioning might change lung recruitment and oxygenation. In this study, they were able to combine CT scanning with electrical impedance tomography to visualize and measure these changes. Prone positioning led to less hyperinflation, more lung aeration, less non-aeration, but the distribution was really different in the dorsal and the ventral components of recruitment. So that when you go into the prone position, as you would expect, you're going to have some loss of recruitment in the ventral aspects of the lung, but of course, a significant recruitment improvement in the dorsal aspects of the lungs, leading to an overall balance in favor of more lung recruitment. And this is then translated in this image that summarizes what happens. In blue, you can see the ventilation. In red, you can see the perfusion in the supine position. And when you move on to the prone position, you can see the two of them overlapping in a way that would explain or suggest an improvement in VQ matching by a better matching of ventilation and perfusion. In this study, there were clear-cut changes in oxygenation, but there were no changes in plateau pressure, driving pressure, and respiratory compliance, suggesting that the VQ matching improvement was the driving force. However, even though we have these insights into the pulmonary consequences of prone positioning, there really hasn't been much about the cardiovascular consequences of prone positioning, particularly in COVID-19. And so we proceeded to analyze what the changes might be in a group of 18 patients as listed here. We monitored cardiac index every minute using pulse contour technology. And what you can see in this graph is when you go from the supine to the prone position, there are changes in the cardiac index of the patients in favor of prone positioning. So prone positioning appears to have a cardiovascular effect as well as a pulmonary effect. And this separation between supine and prone position in terms of the cardiac index continues over a significant period of time and remains steady. You also increase blood pressure. This is a detailed assessment every minute summarized here, and there is a very high and highly significant difference. So there are two cardiovascular events that come from prone positioning: cardiac output increase and blood pressure increase. Of course, if you do that for an equivalent level of oxygen saturation, an equivalent level of hemoglobin, you're going to have increased oxygen delivery. And of course, if you have increased oxygen delivery for an equivalent degree of oxygen consumption, then the mixed venous oxygen saturation must be elevated by this maneuver. And if you have even exactly the same level of VQ matching, inevitably your oxygenation will improve. How big is this effect of gas exchange improvement, and how long does it take to reach its peak effect? This has not really been well studied, and certainly not studied in COVID-19. So we conducted a multi-center observational study of invasively ventilated adults in the city of Melbourne, and we tried to understand these aspects of oxygenation. This is a group of 390 patients, of which some did not have sufficient data on arterial blood gases, and we were able to include 220 patients in our analysis. The average age was 54, mostly of them were male. Obesity was dominant, and you can see the respiratory characteristics in the bottom panel. The average number of proning episodes in these patients was 3, and the average duration of prone positioning was 16 hours. And you can see there the first prone position resulting in an increase in the PF ratio of 72. And the time to maximum ratio change was 9 hours. And you can see that the first prone episode was the one that had the greatest effect on oxygenation. This is a graphic representation of the PF ratio in the 8 hours before prone positioning was initiated in our patients. You can see that there's an immediate improvement in PF ratio with prone positioning, and that slowly peaks to about 9 hours and then remains steady. And this has potential implications for how long one needs to keep patients in the prone position and how long it takes to achieve physiological gains. What happens when you return to the supine position after you've been in the prone position? And you can see there the change from the blue, which was before the first intervention, after the intervention, and what happens when you return to the supine position. So there is a loss of the gain achieved with prone positioning, but after that intervention, the supine position gas exchange is improved compared to baseline. So there is a sustained effect. Now, the prone positioning episode, in terms of the change in oxygenation, shows a progressive kind of decrease in the effect of this intervention, but there is a remaining intervention over time up to 3 prone position changes, with the maximum effect remaining at 9 hours. And you can see that in a graphic display. This is the maximum change in PF ratio with the first intervention, the second intervention, the third intervention, and the fourth intervention of prone positioning. Doesn't matter what you do in terms of neuromuscular blockade. Do you get a better effect if you just sedate the patient, or whether you also add neuromuscular blockade? We looked at our patients, and according to clinician preferences, the majority of the patients received neuromuscular blockade, but a significant proportion did not receive neuromuscular blockade. These patients were similar at baseline on a series of variables that made them pretty much indistinguishable in terms of their characteristics. And when you looked at their mechanics and their gas exchange and their arterial blood gases, they also looked very similar. However, when you compare the change in PF ratio according to whether the patient did or did not receive neuromuscular blockade, you can see that those where neuromuscular blockade was applied had a significantly greater improvement in gas exchange with the prone position, and that this improvement was sustained when the patient was returned to the supine position. And when you looked at all of the factors that were present in the patients as variables in a multivariable model, where you also put the neuromuscular blockade as one of the variables, you found that this is an independent predictor that you will have a greater improvement in gas exchange with prone positioning, which also is associated after the first, the second, the third, with a better sustained effect when returning to the supine position. So let me conclude by saying the prone positioning appears to improve dorsal recruitment and worsen ventral recruitment, but overall the balance is favorable. It appears to improve VQ matching as yet another mechanism to improve PF ratio. It also has cardiovascular effects. It increases the cardiac index, and it increases the blood pressure. Once you do prone positioning, you achieve your peak effect at 9 hours, and it may not be necessary to go beyond 9 hours of prone positioning. The effect gets less as you do your second or third or fourth intervention. It is partly reversed upon returning to the supine position, but an effect remains. These effects appear to be greater if the prone positioning is done with neuromuscular blockade. And of course, this information is useful for people that are applying prone positioning so that they apply the best possible strategy to the patient management.
Professor Bellomo, fantastic talk. Congratulations as always. Any questions from the audience? Oh,
yes, there.
Professor Marini, por favor, please.
Microphone's coming.
The mic is here, arriving.
Rinaldo, excellent presentation, and I agree with everything you said. I'm wondering if you think that taking the patient from supine to prone, by pushing on the abdomen, may translocate some of the volume, the vascular volume, from the belly to the chest to support the cardiac index.
Absolutely. And I can tell you that in the two hospitals that I am an attending at, the procedure of prone position, it comes with a very significant pillow located in the abdomen as well, obviously facial protection. And I am sure the compression of the splanchnic organs and increasing venous return is a significant component of the change in cardiac index.
Great.
Excellent. Professor Gattinoni?
Oh, the big guys. Hey, hi, Luciano.
It's a veterans meeting.
Yes, that's right.
Well, you didn't mention the time.
Right.
Because, and you didn't mention how many of patients did not respond or even deteriorate. And I think the time and evolution of the COVID has a tremendous impact on that.
Yeah.
For what the bellow is concerned, we did years ago a study comparing with or without abdominal support. And we couldn't find, not in COVID, of course, before, any difference. As theoretically, it should be done. But I think that the timing of the timing of support and also the loss of response with time has to do with the change of the disease nature.
That's what you showed in your study there, right? Over time, there is more consolidation and less atelectasis in the study that you did in 25 patients. So I think it's real. These patients were in their first day of ICU admission, but they were on their 9th day of disease. So they were in their 2nd week of disease, but really got prone after intubation. So within 12 hours or so of intubation, they got prone. But the disease, on average, was 9 days. Yeah.
Thanks.
Great talk. I have 2 short questions. The first is, what is your main hypothesis concerning the interaction between neuromuscular blockade and the oxygenation response to proning? And the second one, you showed that there is a mix of oxygenation and cardiovascular effects. We know that the PF ratio is not a good predictor on the survival associated with proning. What is the main mediator of that survival?
I think just going back to the first question about the cardiovascular changes, right? Let me just go back to. I'll just answer the last one, and we'll go back to the first one. It is true that the improvement in gas exchange does not predict the patient's outcome. I think it's much more complex. There is immunological modulation, steroids, baricitinib, tocilizumab, and all sorts of stuff. So, however, what you do in ICU, you try to achieve physiological gain in order to give the patient the longest possible time to recover if they're going to recover. And we understand that. And during the COVID pandemic, the use of prone positioning became a dominant technique, at least in Melbourne. And you can see there 220 people proned. We had very good teams, it was safe, and people did it. But none of us expected that it would change patient survival. However, gaining some physiological outcome was desirable. Neuromuscular blockade, I'm assuming that the compliance of the thoracic cage that makes it possible for the extension achieved with mechanical ventilation and dorsal recruitment to be better if you got muscle relaxation, but I can't prove it.
Okay, perfect. Congratulations.
So we are going to move on to scrutinize more the respiratory and cardiac interactions with Luigi Camporota.
Thank you very much, and good afternoon, everyone. It's a pleasure to be here. I don't know whether I can ask. Oh, thank you, technical team. I thought I had 16 hours, 20 minutes to talk, so that's all great. Well, I would like to thank also Professor Bellomo for introducing already some of the subjects. So I'm going to concentrate in the next 15 minutes mainly on the physiology, and we'll see whether that makes sense. I try to put it together for you. So this is the general idea. So we've got a lung that follows a gravitational gradient. We've got pleural pressure increases. And then we have a superimposed weight and pressure from the ventral to the dorsal regions. And so what we see is a loss of variation in the dorsal regions over here. But then when we compare it between supine and prone position, we can see a profound mismatch in ventilation perfusion. And that's very important in terms of a gas exchange, as Professor Bellomo has already alluded to. But I'm going to look at the implication for the cardiovascular function of this. And so you can see here, for example, more ventilation, less perfusion. And then here you've got matching in prone position with less dead space, so more ventilation perfusion on the ventral regions. regions and less shunt. So you've got much more homogeneous ventilation between the supine and the prone position. So this is the gas tissue ratio from the sternum to the vertebrae. Now you can see much more homogeneous. What it means, this has got implication in terms of the vascular perfusion and the pulmonary vascular resistance in the ventral regions, and also hypoxic vasoconstriction on the dorsal regions. Both of them, as we will see, will have an effect on the cardiac performance. So this is a very complex one, and I don't mean to go through it, but I want to say there are several mechanisms by which prone positioning might improve cardiopulmonary dynamic from a vascular perspective, as well as gas exchange. But I want to draw your attention, just this one on the right-hand side, and as we apply a pressure to the ventral region, just by virtue of being in supine, from supine to prone, you can see that there is pressure applied in the pericardial space. So the pericardial pressure will go up, the pleural pressure will increase, and as a consequence of that, we've got a reduction in the transpulmonary pressure, which will have an effect on lung protective, but also we'll see in a second how pleural pressure will influence hemodynamics. So with that, we'll go straight into the middle of the talk with the hemodynamics. And I want to show you some statistics. And although on average we can see sometimes some improvement in the hemodynamic, that's by no way universal. And this is what it shows, the literature. So if you look at patients, 107 patients, for example, with cardiac output measurement, 25% show an increase in cardiac output. 52%, so half of the patients, will show no change. And 23% show a reduction in cardiac function. So I think it's important for us clinicians at the bedside trying to understand, perhaps identify patients who might fall into this category over here, the one in the middle, or the one that we want to avoid, the one on the left-hand side, where the cardiac index and oxygen delivery is impaired. And I just give just a little summary, just a little taste of what is coming in a second. The ones that tend to be more towards the increase in cardiac index or output, there will be the ones that tend to be fluid responsive, tend to have lower cardiac index in supine position, and the ones that, again, some of these changes might be reversible when we go to supine to prone. But one thing to say is that seems to be that cardiac index or the effect of flow and the effect on the pulmonary vascular resistance, they go together. So, for example, this is a study that shows between supine, you can see toes towards the ceiling or toes towards the ground. You can see supine patients will have to have a greater pulmonary vascular resistance and lower cardiac index, and then the same patients, when prone, had a lower pulmonary vascular resistance associated with a greater cardiac index. But this is interesting, but does it make any difference in terms of prognosis? Well, I put together some studies here. You can see this is cardiac arrests between supine and prone position. This is the PROSEVA study. You can see 6.8% of cardiac arrest in prone position, 13.5% of cardiac arrest, in prone position, 13.5% in supine. All the ones I show here, there is no p-value, but they're all statistically significant. Extrapulmonary cardiovascular free days, longer in prone position, shorter in supine position. And again, you can see cardiovascular normalization of RV function. So everything going into favoring the positive cardiovascular effect of prone position. Now, I want you to take a deep breath, because in this, with this slide, I'm going to talk a little bit about a model that, is a Gattinonian model, where we can explain some of the, or at least interpret some of the changes that may occur in prone position. So if you bear with me 1 second, so you can see this one is the classic venous return curve. So you can see cardiac output or flow on the y-axis, and you've got pressure on the x-axis. And you've got here, you've got the mean systemic filling pressure, so the stressed volume over the compliance of the system. And that slope there is the inverse of the resistance to venous return, so the conductance of the system. And the other one, the red one, that's the cardiac function curve. So you start with the pericardial pressure and goes up with a slope that is inverse of the resistance. And when the two curves meet, so this point here on the pressure point is the right atrial pressure. Okay, why am I telling you this? Because this is what determines cardiac output, is the driving pressure to the venous return, which is the mean systemic filling pressure minus the right atrial, divided by the resistance. So that's Ohm's law. Now, what happens when we give fluids or the patient changes position, like from supine to prone, and like Professor Bellomo was saying, there is an increase in fluid shifts, so much so that the capacitance of the system increases, the mean systemic filling pressure increases, so the whole of the curve shifts to the right. And if there is no change in resistance, this is very important, as we'll see later on, you will see that for the same radial pressure, we'll have here in green an increase in cardiac output. Okay, this is a patient who responds really, really well to prone positioning. However, and you can see that delta has increased. However, this is a problem with the abdominal pressure. Now, what we'll see here on your right-hand side, there's been a shift in volume, so the mean systemic filling pressure has increased, but now the inferior vena cava is compressed. Now we've got a change in the slope in the venous return, and now, although there is more fluid, more volume, the change in cardiac output is much less. So you can see it's a bit more complicated, and you'll be pleased to know that I'm going to make it a little bit more complicated before I can make it simpler. So this is what happens. So imagine a patient in a supine position. That's the optimal situation. We've got the same ohmic changes, so mean systemic filling pressure minus atrial pressure. And now we've got this. Look, there is no change in fluid status. So the mean systemic filling pressure does not change. So this is a patient who is not fluid responsive in prone position. And you can see that delta change in cardiac output is minimal. But now we've got another situation. We've got a patient who, from supine, goes to prone position. Big change in the mean systemic filling pressure, but also we've got something else. We've got the resistance to flow has not changed. The two blue curves are parallel. But now look, the heart has improved. The curve to the heart is a little bit steeper. So that means there is better conductance, less resistance to outflow. And why might that be the case? It's because the pulmonary vascular resistance have decreased, there is less over-distension, and then the PF ratio has improved, the CO2 has come down. That will relax the pulmonary vasculature, and they'll make it easier to get a right into the pulmonary artery, and therefore better left ventricular filling pressure. And the interdependence between the right ventricle and the left ventricle is so much better that the output increases. So that's what is the perfect responsive patients. Now, let's see, you can see the best thing has happened here is the driving pressure to venous return has increased. But now let's see a situation when the abdomen plays a role. And now we've got problems in terms of venous return. And now you can see there is the same change in systemic filling pressure, but now the curve is flatter. So there is more resistance to venous return. And now you can see here on the cardiac output axis that change in cardiac output has decreased, even if the patient has increased the capacitance. And this is important. Now, this is a patient who is mechanically ventilated, and the hemodynamic and respiratory interactions are very important. So I want to expand a little bit on determination of the right atrial pressure. Now, if you take that into a mechanically ventilated patient, you can see that the right atrial pressure actually depends on the change in pleural pressure and depends how the transmission of the airway pressure goes into the chest. And therefore, the ratio between elastance of the chest wall and the total elastance, but also the recoil pressure of the ventricle. And I'll show that in a second what I mean. So, what influences? Let's see, for example, that you've got a situation when the pleural pressure increases. Now, the chest wall elastance increases, and the venous return, resistance to venous return increases as well, and I'll show you the case. This is a situation where you might have a reduction in cardiac output. And for example, what might determine an increase in pleural pressure? An increase in intra-abdominal pressure, stiff chest, again, intra-abdominal pressure, RV dilation and volume status, and most importantly, the relationship between volume status and the change in intra-abdominal pressure. I want to make this one a little bit more expanded a little bit, and I'll show you the value or the importance of the intra-abdominal pressure that goes a little bit in response to what Professor Marini was asking earlier on. And if you think about intra-abdominal pressure, it can have so many effects. Look, it can affect the mean systemic filling pressure. So imagine you've got the pressure inside the venous system is greater than the intra-abdominal pressure. Actually, increasing the intra-abdominal pressure pushes a lot of fluid into the chest. So the mean systemic filling pressure increases, and the cardiac output will increase as a consequence. However, we'll also increase the pleural pressure because it's transmitted to the chest. And it might also increase the stiffness of the overall chest wall, and might also increase the resistance to venous return, particularly when the intra-abdominal pressure is greater than the intravascular pressure, so-called Tanaka, similar to the West zone you can see on the right-hand side. So I'm going to summarize because I've got a few seconds left. And what is happening in prone position, there are three main things. We've got increased lung aeration on the right-hand side, change in gas exchange, and as a consequence of that, the pulmonary vascular resistance go down. We also have an increase in intra-abdominal pressure, and this is always true. But also what will happen is that the hemodynamic will change and the preload might increase. So now let's see what happens once the mean systemic filling pressure increases. We can have two conditions. Either the mean systemic filling pressure increases more than the atrial pressure, which is the case when the thumb is up. In that case, we've got a situation when if the patient has a fluid responsiveness, the cardiac output will increase a lot. However, If there is no increase in that driving pressure to venous return, then we are looking at resistance. If the resistance increase is moderate, then we've got no change in cardiac output. But if the resistance to venous return is massively increased, as in proportion to the delta change in driving pressure, the cardiac output will go down. So this is in one slide my summary, and with that I would like to thank you for your attention, and that's my summary over there.
Excellent talk. I see that Michael Spinsky is already...
I can see an easy question coming.
Absolutely.
First of all, Luigi, thank you for tackling this very difficult, complex cardiopulmonary interaction and doing it very well. My question to you has to do with the resistance to venous return. Because as you correctly said, it is not resistance, but it's conductance.
Yes.
And so one of the things which we've been postulating is that some of the reason why resistance to venous return may go up in some patients is because you've decreased the number of parallel blood flow, not just collapsing the inferior vena cava, as would happen if the critical closing pressure of the arterioles going into the gut goes up. And so what would you say about that? And that's my only question.
And I think you're absolutely right. And so, yes, I think in a way, some of the things, they need to be simplified a little bit. But yes, there is a one single choking point at the top, which is not necessarily associated with a collapse of the IVC, but functionally, there is a decrease in conductance. Yeah.
I wanted to say I have to leave now to give a tutorial called heart-lung interaction.
Oh, excellent.
Luigi, congratulations for your great talk. I'm here.
Yes.
And I have one question. Oh, sorry. For you, Luigi.
Yes.
I'm very worried about the hemodynamic impairment in prone position. And your talk was amazing because it was so clear. But sometimes this hemodynamic impairment was associated with no modification in the PEEP level from the supine to prone position. Yeah. And most people, oh, I'm so happy because of oxygenation improvement. But oxygenation improved associated with sometimes with an increase of dead space, not only the regional changes in the hemodynamics. Don't you think it's important to tell the audience, you know, the importance from supine to prone position to check the PEEP level and evaluate even though the oxygenation improved?
Yes.
Because in that formula, I thought that it was amazing to add a PEEP there.
Yeah. No, I think you're right. It's always a respiratory cardiac interaction, and obviously the more elements to it we add, the more complex it becomes. I've taken the view that there was no change in PEEP and no change in airway pressure, and all the changes were due to a redistribution of the gravitational axis and the fluid shifts. But clearly all that issue of PEEP, it will add complexity to this already scenario, but I agree with you, it needs to be taken into consideration. Yeah.
Thank you so much, Luigi, for your talk. Thank you. So let's move forward, and I'd like to invite Domenico Luca Grieco from Rome, Italy, to talk about awake prone positioning. Thank you so much.
Good afternoon, thank you. Good afternoon, ladies and gentlemen. So in the next 15 minutes, I will try to deal with this relatively new topic. And I find it interesting because it's one of those topics in which the clinical data came before the physiological data. So physiological understanding of the mechanisms behind awake prone position came after the at least 2 trials that we see on clinical outcome. And this is because of the COVID-19 pandemic. So these are my conflicts of interests. And I will start with this, which was the first actual big comparison between the use of awake prone positioning in hypoxemic patients with the rationale of replicating the clinical data that we had for prone positioning in intubated patients is recommended by guidelines. And in this meta-trial, they actually gathered the data from different centers and showed first that actually prone position improves oxygenation and reduces respiratory rate. So in terms of physiology, there is something that is really consistent in the different investigations, which is the improvement in oxygenation and the reduction in respiratory rate. What I really also want to highlight, if you look at the first graph, the other significant effect that was seen in different studies is that when patients were resupined, the oxygenation worsened significantly. And there are reports that in some patients, the PF ratio tended to be lower than the PF ratio before the proning sessions. And when looking at the clinical outcome, you see that there was a signal. Well, here it was significant. It was more than 1,000 patients, that treating patients with session of prone positioning while receiving mostly high-flow nasal oxygen could reduce the rate of treatment failure and reduce the rate of the need for endotracheal intubation. But obviously, we want to have data that clarify also what patients may benefit the most. And as you see here, the authors did a nice analysis showing that the patients actually that benefited the most in terms of clinical outcome were those that could keep the prone position sessions for prolonged periods. So this is an important message that patients tend to benefit from the intervention when they manage to stay in the prone position from prolonged periods. And this is important. This is something that we can discuss afterwards. Afterwards, we had a first pure randomized controlled trial conducted by Yassin Arabi, always in COVID-19 patients, in which patients were actually randomized to receive either conventional treatment or prone positioning during non-invasive support, mostly high-flow nasal oxygen. And as you can see here, the effect of prone positioning in these awake patients was not significant in terms of clinical outcome, in saying endotracheal intubation or mortality at 60 days. So taken together, this data from randomized trials indicated there may be something different compared to the use of prone positioning in intubated patients. So if we have in mind the Kaplan-Meier of the PROSEVA trial, in which there was a huge difference in intubated patients, it seems that this is not the case for non-intubated patients. And I think one of the most relevant components of the reasons that could be behind this is the fact that while in intubated patients we need to prevent ventilator-induced lung injury, the mechanisms of injury during spontaneous breathing are a little bit different. So there is a component related to ventilator-induced lung injury, so strictly related to tidal volume and tidal volume distribution in the different areas of the lung. And there is one component which is the lung injury related to the degree of inspiratory effort, which we call usually self-inflicted lung injury. So while in intubated patients, the abolishment of spontaneous effort makes ventilator-induced lung injury the most relevant determinant of additional damage to the lungs. In spontaneously breathing patients, we have patient self-inflicted lung injury, and this is related to something which is the inspiratory effort. And related to this, one should ask whether the intervention that we are applying, so awake prone positioning, does it affect the risk of self-inflicted lung injury? And I would start with this, which is a very well conducted experimental study by Takeshi Yoshida, in which they could not use. They could not keep the animals non-intubated because of issues related to the lung injury. So they induced lung injury and they kept the animals on spontaneous breathing, so on assisted ventilation. And in one group, which is the these squares, animals were placed in this prone positioning, and in the other group, which is the rounds, animals were kept in supine. If you see the inspiratory effort, which is the negative swing in the esophageal pressure, is higher in the supine group. So it seems here that prone position in intubated animals undergoing pressure support could reduce inspiratory effort and then ideally self-inflicted lung injury and transpulmonary driving pressure, which is the sum of the pressure support that you apply and of the inspiratory effort of the animal. And when they did autopsy, actually they saw that prone positioning during assisted ventilation could reduce the damage produced in the dorsal part of the lung, which in case the animal is supine is dependent, and in case the animal is prone is non-dependent. But actually the most protected part is the dorsal part of the lung. And then some data from human studies started to come out. And this is something that was performed by Professor Chiumello in Milan, and this was a nicely performed physiologic study in which, if you see, they assessed work of breathing with esophageal manometry, and they tried to determine whether the prone position could affect work of breathing and inspiratory effort, which we understand is a major determinant of self-inflicted lung injury. And if you see, prone positioning was associated to a reduced work of breathing. But if you look at the inspiratory effort with esophageal pressure inspiratory swing, you see that there is no difference, at least in this study, between supine and prone positioning. Because what we have seen in the initial slide, so because of the effect of prone positioning on respiratory rate. So work of breathing is inspiratory effort and respiratory rate. Prone positioning seems to affect work of breathing because it reduces respiratory rate, not the inspiratory effort. And this is why we try to look more in detail at the mechanisms behind the effect of prone positioning. This is a study that we did in Rome. And through electrical impedance tomography, we tried to assess the effect of the intervention both on the inspiratory effort and the lung inflation pattern. Essentially, we derived the flow from the EIT signal, and we measured the esophageal pressure both in supine and in prone position during spontaneous breathing and high-flow nasal oxygen. These were quite severe patients, so 130 of PF ratio, and were treated for 1 hour in the supine, 1 hour in the prone, and 1 hour in the supine again. And we were not surprised to see here that prone positioning reduced respiratory rate, on the first slide, but increased the inspiratory effort. Then, through some mathematical modeling on the tracing, we could assess whether the increase in the inspiratory effort was related to the elastic workload, so the driving pressure, which is on the right, or the resistive pressure. So the additional part related to inspiratory resistances. Essentially, when the inspiratory effort is needed to overcome the elastic properties, in this case, unfortunately, only of the lung, and the resistive properties of the airway. And what we found is that the inspiratory effort was increased, and this was due to an increase in airway resistance with a prolonged time constant, which is consistent with the fact that awake prone positioning reduces respiratory rate because prolongs expiratory time. Essentially, what we saw is that the major effect is related to a change in the expiratory time because of increased expiratory resistance and increase in inspiratory effort, not because the lung is stiffer, but because the airways are have a higher resistance. And it was nice because I tried to look at the data coming from studies in the 80s and 90s otorhinolaryngomatory studies and stuff like that. And all of these studies demonstrate that the prone positioning, especially with the face in the lateral position, generates increases in the risk of obstructive sleep apnea and increase in the expiratory resistances. And regarding the part of lung injury related to the conventional accepted mechanism of regional overdistension, so the Vili component of the damage, you see that consistently with what happens in intubated patients, prone position generates a shift of the tidal volume towards the dorsal lung regions. And this ends up essentially reducing the strain, which is the mechanical distortion provided by tidal volume in the aerated lung. And you see here that the general amount of strain is reduced in the prone positioning compared to supine position. This is the regional strain calculated with the electrical impedance tomography. The red indicates the areas where the strain is greater than 2. So the tidal volume is greater than twice of the functional residual capacity, assuming with the high flow that the alveolar pressure is 0 in this case. So this takes to my conclusion. I think that awake prone positioning is different from prone positioning in intubated patients. We have data showing that earlier and longer awake prone positioning can be associated with better outcomes. That for sure there is a mechanism for lung protection related to a redistribution of tidal volume towards the dorsal part of the lung and a reduction in the dynamic strain. But the issue is that awake patients in the prone position may increase the inspiratory effort. So I think the future research, this is something that we often discuss with colleagues, future research should be tailored to identify non-invasive manners to assess the inspiratory effort, because maybe there are techniques that can be effective in patients maybe with a low inspiratory effort and techniques that are needed when the inspiratory effort is high. According to this data, I would say that there is some clear indications that maybe patients with a low inspiratory effort would benefit the most from awake prone positioning. Maybe instead there are other patients with a high inspiratory effort in whom awake prone positioning could even worsen this condition and be associated to a worse outcome. Thank you very much.
Congratulations, Dr. Grieco.
Sorry?
Congratulations.
Thank you.
Excellent. Questions of Professor Gattinoni?
This is complicated for me.
Don't worry, we are here.
This is sort of Italian session, because
Yeah.
thank you, Domenico. But always, when I read all this paper, 2 million of people in awake position, put in prone position, and so on, there is no one who report one simple question. Did you ask the patient if he feel better in prone position, yes or not? Because if he's awake, it's the best thing to ask the patient. And the patient is very, very important. Some patients like to be prone position, some patients refuse. It's quite simple. Or not?
Fully agree with you. In fact, there is, for the sake of time, I didn't show, but there is another study by Gianmaria Camporota. They showed actually that the increase in the thickening fraction of the diaphragm during prone was associated with the outcome. Also in our study, it was not significant because there are 15 patients, but those who most increased the effort had discomfort. So at discomfort and worsening dyspnea. So this is maybe why in your study, for instance, the prolonged sessions were associated with a better outcome, because maybe those who were reprone very early were those who had discomfort, as he said. Yeah.
Yeah. Do you think about the vagus stimulation in awake patients, in awake prone position patients, Because, for instance, we know that when we have an inflammatory process, even though adults, they have more vagus stimulation. And when we have this kind of stimulation, we change the respiratory rate, the tidal volume. Do you think that it may be a mechanism?
Honestly, I do not know. Also because the real explanation why patients with ARDS and acute hypoxemic respiratory failure start to breathe with like 20 of delta Ps is not very clear. So maybe we should understand why they breathe with those kind of breathing pattern, and maybe afterwards, yes, for sure, could be an intervention to modulate it. Yeah.
Think about the mechanism.
Yeah.
There's another question?
Going back to the point raised by Professor Gattinoni, there is a part that comes from the patient. Some patients are more prone to feel better proning than in supine. Most of you, I'm sure, that sleep proning or supine, and it's patient dependent. But the other part is how, if we could implement some techniques or some distractions that facilitate that the patient could be more hours in prone position than in supine. Simply giving them the mobile on top or whatever that feel better in the prone than in supine. And this was a discussion that we have when we published the paper in Lancet, because the difference between countries were quite different. The Mexicans were the better in terms of keeping their patients in prone. And part of us is how convinced we are about the technique. It's like in NIV. I mean, if you explain to the patient that we have the problem with the helmet, you know that, because we are... No, I mean, we are trying to start with helmet.
I'm starting to having problems too with helmet.
And the first thing is to convince our professionals that it could work, because then they will convince the patient that it could work and the patient would feel more comfortable.
Mm-hmm. Excellent.
I have one question. So if your main hypothesis concerning the rise in inspiratory resistances is a positioning and that the obstruction is proximal, do you think devices allowing the head not to be turned in prone positioning could be a potential solution to that?
Yes, absolutely, because one of the... I found some data that the increase in resistance is distal and is gravitational, so are lower airways, and other that are upper airways. For sure, one way to discriminate between the two could be the fascial support that is used for intubated patients, but honestly, I never tried into non-intubated patients.
And they could watch a film or to advertise.
Thank you so much. Excellent. Sure.
So it's time to move on to the second part of the session, and we will start with Giovanni Landoni. Even with NIV or CPAP and outside the ICU, we can do proning.
Hello to everyone. This is my San Raffaele Hospital in Milano. I have no conflict of interest. These disclosures are not going to affect my talk. Probably my only disclosure is that in my hospital we started performing non-invasive ventilation outside the ICU 30 years ago, and we started publishing 20 years ago about our experience. So we love non-invasive ventilation, and over the decades we performed a lot of training to all the hospital personnel. So in March 2020, I entered into a COVID room patient of my hospital, and I found this patient in this position and with this non-invasive ventilation. So I closed the door and I entered again, and the patient was still there. So I went close to him. I asked how did he feel. He feel comfortable. Then I asked my colleagues what happened. He was waiting for an ICU bed, and they decided to put him in the prone position while on non-invasive ventilation. So I don't know if this is a first in COVID or not, but I asked my colleagues to collect some data, and we soon published it in JAMA. The editors were really fantastic in understanding that this was really at least a bit strange. Of course, they asked us to completely rewrite everything, and we had to recollect all the data afresh because they didn't like it. So at the end of our first wave, this was on April the 2nd, we did a survey of 1 day in all our hospital. We had only 48 patients in the ICU and only 202 in medical wards, 62 of them with CPAP. I say only because this was really the end of the first wave, probably thanks to seasonality, not only to lockdown. And on that day, there were 15 patients pronated with non-invasive ventilation. They were there because saturation was suboptimal with in spite of 10 of PEEP and high VO2. And they had a poor response to traditional non-invasive ventilation. NIV cycles were individualized based on patient severity of illness. On that specific day, they were receiving 2 sessions of prone positioning of 3 hours each. They were pretty young, and they did well. It means that 2 weeks after, one was dead, and the majority of the others were okay. These are the results. So how did they do? So oxygenation, of course, improves. I think what is important is the respiratory rate. The respiratory rate went down and stayed down 1 hour after re-changing the position and going into the supine position. I think this was very important. And I think this can answer Professor Gattinoni's question. We did ask them, how do you feel compared to before the pronation? And the vast majority of them felt improvement during the pronation and after we put back to the original position. So our patients were happy to be pronated and ventilated while pronation. Of course, they were fighting for life, and they felt that they were feeling better. The editorial of JAMA was, of course, fantastic. The take-home message for them is that many, but not all patients with hypoxemic respiratory failure tolerate the prone position. The improvement in oxygenation, decrease in respiratory rate occurred, and that the effects were transient. In our case, serious. At least for a few hours, the improvement was there. So I told you about pronation plus NIV plus outside the ICU, and it is even possible to mildly sedate this patient. This looks like a bit like fiction, but together with Gianluca Paternoster, few days after we started proning patients, he started proning patients outside the ICU in his setting. It was a high dependency unit, which was more a general ward than an ICU. 11 patients after failing a CPAP trial. He sedated, mildly sedated, 7 out of these 11 patients with dexmedetomidine. And again, he found improvement in several parameters, including a reduction in the respiratory rate and a reduction in lactates in the days following the pronation. I think this is pretty important. Also, his patients did pretty well overall. Of course, these are just observational small case series. On the second wave, he did it again, pronation, outside the ICU, and the only difference was the way that the patients were sedated, so approximately the same number of patients, but not with dexmedetomidine, but with a mix of other sedative agents. So, by the way, this is Gianluca Paternoster, who is a fantastic colleague and a friend. We searched deeply into literature, and we found no other subsequent report, with the exception of this one. It is difficult to understand if it is CPAP or if it is only high-flow nasal cannula, but the findings are the same. Patient seems to improve, comfort seems to improve, respiratory rates goes down. To tell the truth, we also found one single study which reported the use of non-invasive ventilation, the prone position outside the ICU, immediately before the COVID pandemic. This is a January 2020 article that we discovered after doing it in our hospital. Small case series, 20 patients. Overall, the majority avoided intubation. So yesterday, I put this on Twitter. I asked colleagues if they still use NIV in pronated patients outside the ICU. So half of them never did it. There are still 10-20% of centers approximately. Of course, there may be many bias in this survey, which seldom use it in the main ward or in the ICU. This is in contrast to the zero publication that we found in the last few years. What about our hospital? So in non-COVID patients, we did it in 5 non-COVID patients in the last 2 years, which is a very small number. We did it once in the ICU. The main indication is sealing. I mean, if we decided not to intubate the patient or not to admit the patient in the ICU, we gave him the chance of being pronated. On the other side, I think that this experience dramatically changed our behavior, generally speaking. First of all, because of teamwork. Point number 2, we now invest more in physiotherapy and physiotherapists, and there are multiple minor changes that we apply to our patients. For example, maybe we don't do the prone position, but we do the lateral position, or the patient sit in a proper way, maybe not on the bed, but on a proper chair. So I think this experience changed a lot many aspects of our daily practice outside the ICU. This is a fantastic chief nurse in Monza, close to Milan. I think this is himself, so not only he published the paper, but he is the man here, and I think he gave the name to a new, slightly modified dolphin position to put the awake patients while they're being pronated. And this has just been published today, Critical Care Medicine. In the US, when they do things, they do them really big. And this is something like 1 million patients, half of them receiving non-invasive ventilation, and 100,000 of them receiving sedation on top of non-invasive ventilation. I read it only twice. I didn't find out if these patients are outside the ICU or in the ICU or in a high dependency unit. Probably you will discover it. I think the take-home message of this paper is that we should be careful with sedation. Definitely, they found that many patients were sedated. They also found an association of sedation with mortality. Of course, we cannot say if this is causation or association, but the message is clear, and before sedating patients outside the ICU, we must be extremely, extremely careful. They conclude saying that the use of sedation and oral analgesia during NIV for acute respiratory failure may be associated with patient harm. I probably disagree. If I am the one doing a little sedation, it can be possible if it is someone else giving a high dose of some other drug. This is a fantastic position paper, consensus statement of many experts, including Grieco. And here we try to describe step by step how to put a patient who is awake in the prone positioning. We give a few recommendations about which monitor, and we just give some suggestions how to manage emergencies that luckily occurs very seldom. So take-home message of today, this technique, which is pronation plus non-invasive ventilation outside the ICU. I'm not sure if I want to include sedation or not. Probably I would keep it out. It is feasible. Respiratory rate reduces. Comfort improves. Some centers are doing it in a few selected situations. And definitely we have learned a lot from this technique and this experience. Thank you very much for your attention.
Excellent, congratulations.
Thank you.
And we learn a lot with your paper. So, because we are dealing with COVID after you.
Yeah.
And so questions from the audience? Oh, go ahead, Armand.
I have a question. So, in terms of feasibility, do you think that there's a difference between the type of respiratory support, meaning high flow, CPAP, or NIV?
Probably in the same order you mentioned it. So I think it's easier with high flow, a bit more difficult with a mask, and even more difficult with a helmet. But then it's just, I think training with pillows, bed positioning, teaching to the staff and to the patient. I think that all techniques can be quite easily managed when they were performed on a routine base. And the patient comfort on average improves. He really feels that he's doing a bit better. So the vast majority of our patients were happy about it.
And concerning the monitoring, you seemed to recommend some monitoring very similar to what is done in the supine position. But in your experience, don't you have problems with not looking at accessory muscles of the patients? And do you keep the same intubation criteria with this strategy or not?
Yeah, so the the monitoring is that one. Of course, the attention you pay to the patient should be higher. I was talking with a colleague just before coming here, and he's asking me, why are you doing it? I mean, when you put the patient in such a position, someone must stay with him every moment, every time. So it is like being in an ICU. I told him that when it becomes a little bit routinary, you can manage these patients quite easily. Some of them even sleep. You have remote monitoring and alarm. And then, of course, the best answer is that the best monitoring is decided for that specific center with his particular capabilities and training.
Professor Landoni, excellent talk. I'm very, very happy. And now I'd like to invite Professor Luciano Gattinoni from Göttingen, Germany, and he'll talk about don't look at the oxygenation response, another challenge.
Okay, good afternoon to everybody. Well, this is a sort of Italian session because I saw the names.
Yeah, you see.
Spread a little bit around the world. But so prone position and non-loop oxygenation. This is the title. And my view is a little bit different sometimes. If somebody tell me, okay, we have put 1 million of patients in prone position, everybody says 1 million, great, go to the New England. And 80% improve oxygenation. I don't care. Who cares? My problem is, and your problem is, why this patient respond, why this patient did not respond. Makes sense to have this maneuver. The risk of this maneuver are greater than the benefit are greater than the risk. Is less dangerous prone position or mechanical ventilation in prone position than in supine position. Well, I can anticipate my conclusion, so if you want to leave, you can read. Whatever you do bad to the lung is less bad in prone than in supine. That's it. And the risk of prone are quite limited. Now let's go a little bit more in the mechanism. Now, this is a prone position. No? At the beginning, we start prone position. I think we were the first to start prone position. After we looked at this kind of picture, excuse me, when we look here, we say, okay, we have the patient in like this. So for 1 year, we were taking back the patient in intensive care and put in prone position. Why? Because you say, if I put in prone position, I have a better perfusion here and the PO2 goes up. The PO2 went up. Then, after about 1 year and a half, a colleague of mine, a young colleague, was Fumagalli, was taking a CT scan and I said, can we show with a CT scan that we are very intelligent to do that? Said, go ahead. And it come out something like that. The redistribution of densities. Why? And is water? I mean, it's not water because it was too rapid, this phenomenon. If not, we would take care of pulmonary edema, just taking the patient by the head, by the foot, and like this. Doesn't work in that way. So we had a lot of discussion, and we come out with a sponge model, which explain in part the prone position, and explain the PEEP mechanism, explain many things. But if you don't have the characteristics to have something like that, the prone position per se doesn't change much. You have to have some prerequisite for the prone position to work. Now, let's go. Why oxygenation improve? In some of the cases, not in all. VQ, we have more homogeneous inflation ventilation, mass and lung shape, chest wall elastin changes. Okay, let me go a little bit very rapidly through these 3 points. More homogeneous inflation, okay. This is the patients in a normal patients, and you can see this is non-dependent supine position. non-dependent, you can see this one as a sort of alveolar size, okay? Go from 6 down to 3. That means you have a greater alveoli up than, these are the gravitational forces, is well known. In prone position, they tend to become flat. In RDS, these were not COVID, where RDS, that means the classical RDS with a wide lung at the CT, you see exactly the same thing, but of course down because you have the lung, aerated lung is far smaller. Okay? Now, if you take this one, this is the shape of the supine position, you can compute how much is the distance at which you decrease down to 37% the original size. So you have some quantitative measurements of the distance of collapse. And what come out? I don't want to be complicated as my friend Camporota, because he got a headache after your presentation. And you see here that in supine patients, the distance at which you decrease the alveolar side out of 37% is 5 centimeters from the sternum. In prone position, from the top, becomes at about 10 centimeters, the double. That means it's just more flat. So that means the alveoli are more equal. And when we have in a democracy, we have an equal alveoli, they share whatever insult more evenly. And this is the basis of the possible prevention of bad things to the lung. And now, if we, let's see, doesn't work. I have to stop this one.
Do you have another point?
Okay, so if you add the regional inflation, okay, supine 13, prone 26, in RDS 6.5, 9.9, okay. These are the quantitative analysis of what I presented before. And very few patients. But who cares? To understand the mechanism, you don't need 1 million of patients. You need 5 patients, 10 patients well studied, that's it. RDS was described in 11 patients, not in 2 million of patients. And you see that very clearly, when more flat is the distribution, better is the oxygenation. And remember that usually the perfusion remains quite homogeneous distributed in prone and supine. What changed more usually is the ventilation. Now, this is never considered, the mass and the lung shape. Let's see. Here you have the upper lung and down lung, okay? And let's see, I take 50%. And you see that the upper lung, due to the shape of the lung, is less amount of tissue than in the down, the 50% of the lung down. But this may be completely different in individuals. Some patients have the thorax which is very triangular. Some patient is more round. So the response of prone position in part could be written in your identity card. Depends on the shape of the lung and the chest wall you have. And of course, in prone position, I have, if I collapse this one, and I collapse this one, and I open up this one, I have more tissue to be opened than tissue to be collapsed, due to the mass differences. And if we put the difference between upper and down lung, you saw is related with the oxygenation. So look at the patient, is in part of the patient anatomy. Then, the chest wall. Chest wall is quite important because you have, we found that greater is the improvement, the chest wall changes are related to the improvement or deterioration of the oxygenation. And you see here, and you see when you have a patient in supine position, you have this distribution. You don't move the dorsal part. because you cannot move because you have the table, the mattress, whatever. And you move the upper part and the diaphragm part. The diaphragm doesn't change too much. We spoke a lot about the changes in abdominal pressure. We measure the abdominal pressure changes. Very rarely are greater than 1 centimeter of water. So it's not so tremendous changes in that. That doesn't not exclude in some patient maybe, but measure it if you have some doubts. And of course, we try, after we found this one, we try to use the sandbag ventilation, and I patented also a system that was never developed to compress the chest wall during the inspiration just to remodulate, to simulate the prone position in supine. But the system is quite clear. So we have a series of changes, possible changes in recruitment. But remember this one. You take prone position, recruit the lung. Wait a second. Prone position, recruit and de-recruit. And as I think was a slide of Bellomo, when you say, okay, it depends by the balance between recruitment and the recruitment, okay? And this is an example of very few patients in Colby position. If you take the average, it doesn't change too much the oxygenation. But in some patients, we have a tremendous increase of PO2. Some patients, we have a tremendous decrease. And you put together, you have no great changes, which is the problem of the statistics. As if I had one chicken, I divide into the whole story. Which is the problem of the statistics. And remember, we do not cure, we do not take care of the population. We take care of the single patient. So I appreciate Landoni when he presented ask the patient, how do you feel it? Bad, worse or not? So I don't have to oblige the patient. As in the nature, it's quite important to ask the single patients on what's going on. And now let's imagine, very rapidly, let's imagine I have a pure atelectatic problems. That means I have only atelectasis. Atelectasis means an empty pulmonary unit, collapsed but empty. Consolidation means a pulmonary unit which is full of something else than gases. You cannot open the consolidation. You may open the atelectasis if you have. So the problem is, how is the balance? Both appears as white at the CT scan, at the X-rays. You have to test with the pressure to see if it's recruitable or not. Recruitable means atelectatic. Let's see you have a completely recruitable lung, only atelectasis. That means all edema is in the interstitial space and compresses the pulmonary unit. Now, if you put in a prone position, this one is open up and this one will collapse. Of course, this part is greater and the PO2 goes up. Let's see now I have a pure consolidation, which happens, as an example, with time. After 2 weeks, the atelectatic part decreases a lot, after 1 week also. So it doesn't mean anything, say COVID. The problem is COVID when? Immediately at the entry, after 1 week, after 2 weeks, after 3 weeks. If you put together, you don't understand anything. You just play with statistics, but without understanding the mechanism. Let's see that we have pure consolidation. I have this part, which is consolidated, cannot be recruited. I put in prone position, this part compresses the ventral part. So I have the recruitment in the ventral part. I don't have any opening in the dorsal part. And the PO2 what does? Goes down. So when you have the response to prone position oxygenation tell you also something about recruitability and not recruitability, and the nature of the problem you have. I'm still stuck. Can you help me? Doesn't move. There is somebody there?
Yes.
Perfect. Now, oxygenation, everybody knows, is not related to the outcome. But the poor CO2, which is always ignored. You have the PO2 goes up under 50 millimeters of mercury, the CO2 sometimes goes down, sometimes goes up. And nobody cares. Because PCO2 is blue, is not so attractive as the red. The intensivists love the red blood. Huh? But the CO2 tell you about the structural changes of the lung much more than the PO2. Remember, look at the PCO2, look at the total ventilation of the PCO2 is enough, these two information, to tell you about the severity of the patient. And in the patient who get the improvement of CO2 during prone position, had a significantly better outcome. Means that the patient with the greater structural changes benefit more of a prone position than the other one. Which means that all the things that we do to the lung in prone position are probably less dangerous, as I anticipated at the beginning. So, lung homogeneity. And you say one of the more curious of things that I was desperate in my life is that when you say lung and chest wall mismatch. And somebody say, well, it's a lung and chest wall mismatch. What does it mean? It's not so easy to understand. I don't know if it's true what I present now, but in the lung mismatch, you say, okay, we have in supine, this is the form of the lung without gravity in the space. All the alveoli is the same. Now I have to put this form, this shape, in a thorax, which is a sort of cylinder. So I have to match these two, I have to expand more the upper part than the lower part. Then I put the gravity, and the gravity compresses the part below. In supine position, you have the advantage, what we have shown at the beginning. You have a more homogeneous distribution of the anatomy, of the lung size, which is the key point here. Now, well, of course, if you look at the first study we did in 80-something on prone position, after a big fight with the editor, we say very humanly, the patient with the lowest PO2 FiO2 have a significant improvement in prone position. My God, was not preview in the statistic plan, so was shit, out. Don't consider. But the severity of the patient is linked to the response of prone position, because only the severe patient may take advantage of less damage added with the mechanical ventilation. It's quite simple. And finally, after 20 years of several studies, we have that in a fraction of patients you may improve the survival, means you have less danger in mechanical ventilation in prone than in supine. Anytime we compare the symptomatic therapy, we compare the bad, not the good. We do not improve survival. We decrease the mortality due to the doctors. Always seems the same thing in terms of number, but philosophically are completely different concept. Now, very simple thing that I do you have a patient, put the patient in prone position. And the patient, this is not awake, the classical patient, mechanical ventilation. And you look at just the plateau, the wave pressure, and you may, the plateau goes up. Okay, this is normal because the chest wall compliance decrease in prone position. But if the plateau stays there, that means you have changed something in the lung and you have some open. If the plateau goes down, you have a tremendous recruitment. And I may humbly suggest, I don't know if you still have the stethoscope or is in the museum, but if you go to the museum, steal the stethoscope you had, and try to put the patient in prone position, before to put in prone position, put the stethoscope close to the spine. You don't hear anything usually. Keep the stethoscope there. And then leave the patient hearing what's happened. And you will hear in a patient who recruit a rocks. You immediately understand the opening of the patients. That is not always in all patients, but in some patients it's absolutely spectacular. And when this happens, you know that you are recruiting the prone position. These are over in control, in volume control. Of course, if you are in pressure control, the tidal volume in prone position, in normal individuals goes down because the chest wall goes down. This is a natural reaction. But if the tidal volume stays there or even increased, means you have a greater part of atelectacy. So stethoscope, loser, is already more complicated. I still use the stethoscope, so that the ends, the eyes, the ear. Also at my age, you have some problem with all these sense organs. And so, these are my conclusions, because there are a few maneuvers, I think, in intensive care which have a so low rate of complication, if you pay a little bit of attention. We have maybe 4 or 5 cases in all the history of prone position of blindness, but because we're put the patient in wrong position with the compression of the eyes and so on. If you are accustomed to do that, I think is and in awake patients, not only for prone position, for many things, ask the patient if he's awake. Have you cold or are you warm? Before to look at sometimes the monitoring, asking the patient on what they feel when you change something, maybe it's not a completely stupid idea. I thank you for the attention.
Thank you, Professor Gattinoni. Excellent talk, as always. And I'd like to open to the audience any questions. But I have.
You?
Yes.
10.
I know that, but I have. You showed the importance of consolidation. And I learned that we are unable to open consolidated areas. Do you think that before prone positioning these patients, it would be interesting to evaluate the recruitability of the patient? Because even though now it's like a routine in several ICUs to put the patients in prone position, even though sometimes not so comfortable for the whole group, sometimes I believe that it would be interesting. Is it good to prone these patients, or it's better to evaluate the recruitability before proning these patients?
Well, you have to look at the number of nurses you have, the availability of the CT. The first study we did in prone position, we keep the patient in 6 hours in prone position. And everybody say afterwards, but why 6 hours only? You have to But at that time, nobody knew any idea of how long. You know why we choose 6 hours? Because it was the nurse's shift. You have more nurses available to put the patient in prone position, which at the beginning had some problem.
Yeah.
So it's depending, but theoretically, you are perfectly right. If I have a patient completely consolidated, and with the consolidation in the dependent lung regions, prone position theoretically might be dangerous because I compress the anterior part, so my head opening and closing, etc. So, but I think if you just put the patient in prone position and ask the patient in awake, or look at the alveolar, the plateau when you have mechanical ventilation, and use the stethoscope. That give you the information you want.
Yes, you know that I use it. Yes, several years ago, you told us during a talk, please use the stethoscope. And wow, I will try to do so.
Well, my young colleagues start to laugh when I speak about the stethoscope. Everybody, go to the museum. You have to go to the museum myself, together with my stethoscope.
Yeah, me too.
Okay.
More questions from the audience? I have one question. So you highlighted the role of the change in the shape of the lung to explain the PCO2 variation. Do you think lung vasculature may have something to do with that change in PCO2 when proning the patient also?
Well, difficult to say. I don't know if I really understood the organ. But if you have more is the shape triangular, more all the results I showed are exaggerated. If you would have a perfectly round thorax, I think most of the things that we see in prone position we would not see. But we did in very few patients looking at the dimension, but it was very clear. And we have some bicycle champions. Now we had Fausto Coppi, was a champion in bicycling years. He had the thorax like this. Was a sort of cuneum. And this patient in prone position would have responded beautifully. He died because of malaria, but nobody put him in prone position. Right? You remember, Bellomo remember,